So today we will discuss about a very important topic, that is a heart block. It also known as a nodal block or AV block, right? So before discussing the real topic of today, that is a heart block, first we discuss the conduction system physiology of the heart. So the conduction system, the impulses are generated at ST node. So this is ST node. So ST node is a peacemaker of the heart, and can the anatomy of the ST node, the location of the ST node is very important. It is located near the superior vena cava opening, near the superior vena cava opening, right? So from the impulses from the ST node, they are moving toward this left atria. This is right atria. So from right atrium to the left atrium through the Bachmann bundle to ensure that the both of the atria depolarize at the same time, right? From SA node, the impulses are travel toward the AV node, right? So the AV node is located at the interatrial septum. AV node is located at interatrial septum. So this is the high yield point, interatrial septum near coronary sinus opening. So what is the blood supply of this AV node? Right coronary artery. Okay. So that's why the inferior wall MI, inferior wall MI is fluted the right coronary artery. So that's why the inferior wall MI present with the bradycardia, because damage of these nodes, right? Okay. So from the SA node, the bundles are travel in the bundle of, the impulses are travel through the bundle of his. So this is bundle of his, this one, right? So from the bundle of his, the bundle of his divided into the left bundle branch and right bundle branch, right? So the right bundle branch supplies to the right ventricle and left bundle branch supplies the left ventricle. So these bundle branches are further divided into the fascicles and Purkinje fibers. Fascicles and Purkinje fibers. Okay. So uh, first we discuss short bit about the tachycardia that we will discuss tomorrow. But here is the important background. So the tachycardia are generally divided into the pathological tachycardia, narrow complex, tachycardia, and broad complex. Complex means narrow complex QRS. Broad complex QRS. Broad complex. So this is tachyarrhythmia. Okay, so tachyarrhythmia. So the narrow complex tachycardia, the QRS is less than three small boxes. Less than three small boxes mean 0.12 milliseconds, right? And broad mean more than 0.12 milliseconds. The QRS duration. Okay. So the narrow complex tachycardia, the pathology lies above the AV node. So the narrow complex tachycardia pathologies lie above the AV node. AV node, within AV node or above the AV node, right? Does it make some sense? Hello?
Can you go over the last? Yes, can you go over the last part?
Okay, so the narrow complex QRS,
Okay,
tachycardias or tachyrhythmias, the pathology lies above the AV node or within the AV node, right? While the broad complex QRS tachycardias, the pathology lies below the AV node, right?
okay,
Okay, we will discuss these tachyarrhythmia in detail tomorrow, right? So the narrow complex QRS included atrial fibrillation, atrial flutter, the paroxysmal supraventricular tachycardia, or multifocal atrial tachycardia. So while the broad complex QRS tachycardias include VT, ventricle tachycardia, VFib, ventricle fibrillation, and torsade day point. So don't worry about this. We will discuss these tachyarrhythmia in detail along with their ECGs. So their ECGs are the super high yield stuff. Okay. So this is some review of the ECG. Although I already made a session on the ECG, short session on the ECG. This is again the revision of some basic point of the ECG. So, so again, the P wave represents atrial depolarization. ECG basically represent the electrical event of the heart, not the mechanical event. Atrial depolarization. So the PR interval is a very high yield. So the PR interval, what is the significance of the PR interval? PR interval signif signif signify the represent the AV nodal delay. So why AV nodal delay is important? To ensure this delay to ensure the ventricular filling. Okay. And the clinical importance of this PR interval. This PR interval is increased in heart blocks. Increase PR interval in heart blocks. So the normal duration of the PR interval is 3 to 5 small boxes. And you simply see that one large box, right? Okay. So the QRS complex. So QRS complex represents QRS complex or QRS interval are the same thing. So it represents the ventricular depolarization. Ventricular depolarization. Okay. So ST segment is important in clinical important in the MI myocardial infarction, ST segment elevation or uh, uh, non-ST segment elevation. It represents the ventricular completely depolarized, and T wave represent ventricular repolarization. And U wave sometimes this is not a this is U wave sometimes found in the hypokalemia and bradycardia. Hypokalemia and bradycardia. This is not a normal finding, U wave, right? So the in so PR interval is important. So the PR interval is increased in heart block, right? PR interval is increased in heart block. So the heart block are divided into three types: first degree, second degree, and the third degree heart block, right? So the heart blocks, second degree is further divided into the two types: type 1 and type 2. Okay. So uh, I'm going to change the slide because the heart block are important in point of view the ECG. So we will discuss the main ECG, right? So heart blocks. Okay. Heart blocks. Is my screen is again visible or not?
No, it's off.
Still not visible?
No, not yet.
Just give me a minute. Just give me a minute. Okay. Still not visible. Still not visible my screen.
No.
Okay, I'm trying again. Okay. So the heart block are divided into the three types. The first degree, second degree, third degree, right? So the
Yes.
first degree heart block is simply prolonged PR interval, right? So this is P wave, this is PR interval. So it is almost more than one large box, right? So this is again in large PR interval, in large PR interval, in large PR interval. And then notice there is no drop beat. That what is meaning of the drop beat? You found that P wave is followed by QRS. P wave is followed by QRS. P wave is followed by QRS. Right? The only thing is prolonged PR interval. Prolonged PR interval, more than one large box on the ECG. Right? So it is the benign and asymptomatic. Okay. So what are the causes of the first degree AV block? What are the causes of the first degree AV block? Calcium channel blockers, beta blockers, and strained athlete, right? Okay. So, so one more thing is that is again a high yield stuff. That is again the high yield stuff. Okay. The lesion is very important. The lesion of the heart block is very important. The lesion of the heart block, the pathology lies at AV node. AV node, right? AV node. So, if pathology lies at the AV node, it is benign condition. If it is below the AV node, if it is below the AV node, so it is require treatment and it is severe form, right? So if the pathology in the AV node, then it is benign condition, not severe. So if it is below the AV node, it is severe. Okay. So the first degree and second degree type 1 AV block, the pathology lies in the AV node. Pathology lies in the AV node, right? While the type 2, second degree type 2 and third degree block pathology lies below the AV node,
Sir,
right?
may I ask a question?
Yes.
Okay, so in morbid type 1, when there is a drop beat, why the patient is not having symptoms? Is that drop beat is going to compensated by other QRS intervals following by it?
Okay. Okay. Your question, the drop beat. What is the meaning of the drop beat? So drop beat meaning simply the missing of the QRS complex. So the heart rate is mainly calculated by the ventricle contraction by the QRS complex, right? So what happened? What happened? So there is a drop beat, right? And then this is immediately followed by normal followed beat. So that's why it depend upon the severity of the disease as well, and it depend upon the severity of the disease as well, because one drop beat and this followed by again the same pattern, right? If it is uh, advanced stage, okay. So this is P wave, this is QRS complex, right? So the PR interval is prolonged and this is progressively prolonged, right? And this is again progressively prolonged. So here the P wave is not followed by QRS complex. So if I extend this ECG, if I extend this ECG, what happens? This again P wave. Okay. If I extend this ECG, what happens? This is P wave again, and this is again followed by QRS. So that's why, because it is again followed by the QRS, that's why the sometimes symptoms are not present, but the symptom may be present. This is multifactorial things. The age is important, the underlying pathology is important, so the drug dosage is also important, because the type 1, the causes of the type 1 is also beta blockers, calcium channel blockers, these kind of the stuff. I hope it makes some sense.
It's a little bit confusing.
Yeah, it's clear. Thank you.
Okay. I'm explaining another thing that is important in case of the USMLE point of view. Okay. So the level, AV node, within AV node or below AV node. Okay. If the lesion within the AV node, then it is some sort of, you say that it is a not severe type of the heart block, right? It's simply, you can say, the benign. So within the pathology within AV node, the condition include in the heart block are the first degree and type 2 second degree. So below the AV node, the condition are second degree, type 2 and third degree heart block.
Wait,
So that
yeah, excuse me, Doc. I think, but earlier you said that at the AV block would be, the first degree, and then type 1 of the second degree would be at the AV block. Now you are saying that, okay, you just remove it. Now you're saying that below is where you will have the type 1 second degree.
I'm saying that this is a more precise and high yield point. I'm saying that the pathology of the heart block lies in the AV node or below the AV node. I'm saying this thing, right? So these two blocks pathology lies within the AV node, while these two blocks pathology lies below the AV node. So, the, so these two blocks need treatment, pacemaker placement, pacemaker insertion, and these two usually does not require treatment. They only require treatment if the heart rate heart rate below 30. So what is the treatment of choice drug if the heart rate is below 30? IV adenosine. Oh, sorry, IV atropine. So what is the mechanism of action of atropine? It blocks which receptor? M2 receptors. M2 receptors, right? On the heart.
Yes.
Okay. In this way, it will decrease the parasympathetic activity of the heart, right? So one more thing. This is again the high yield. If the pathology lies within the AV node, if the pathology lies within the AV node, so these condition can improve with the exertion. That condition can improve with the exercise. So exercise increase the sympathetic activity, right? Exercise increase the sympathetic activity. So that's why these conditions improve with the exercise or exertion. While that this Mobitz type 2 and third degree AV block are worsens with the exercise because the pathology lies below the AV node. Okay. Again, the super high yield point of this ECG. You have to identify these conditions on the ECG. Okay. So the ECG is important. So the second degree divided into the two types. Type 1, which is also known as a Venki back, and Mobitz type 2. So what happened in the type 2? Type 2 is a progressive lengthening PR interval. This is PR interval. This is you noted that this PR interval is shorter than this one. So this PR interval is greater than this PR interval. So there is a progressive increasing in the PR interval, right? And after that, there is absent QRS. So absent QRS means drop beat. While in the first degree AV block, there is no drop beat, right?
Right.
And what happened? The variable RR interval. So this is R, this is RR interval. So this is variable. The distance between the RR interval is not same. Okay. So this Mobitz type 1 or Venki back, there is no treatment, usually does not require treatment. If it is symptomatic, then you treat this condition, right? And the pathology lies within AV node. AV node. Okay. So Mobitz type 2. The Mobitz type 2 is basically this PR interval is prolonged but fixed. In the Mobitz type 2, this PR interval is prolonged but fixed. This PR interval, increased PR interval, is equal to this PR interval, right? So fixed prolonged PR interval, but the drop beat is also present, right? So you have to make difference, distinction between these different type of blocks on the basis of mainly the ECG. Although, okay, so this is again a drop beat. So there is no progressive lengthening PR interval in Mobitz type 2. So in the Mobitz type 2, the pathologies lies within which area? Below the AV node or within the AV node?
Type 2 is below the AV node.
Okay, so below the AV node. So below the AV node is a swayed heart block. So you need to treat this condition. You need to treat this condition. How can you treat this condition? By pacemaker, by the pacemaker, by the pacemaker. And this condition is worsened by exercise because the pathology lies below the AV node. This condition may progress to third degree AV block. Third degree AV block, right? The third degree AV block is associated, there is a high yield stuff. Third degree AV block is associated with a microorganism. Which microorganism? Can anybody name this microorganism?
Yeah, Lyme disease, bacteria.
Lyme
Coxsackie
disease.
virus.
No. Borrelia burgdorferi. This is bacteria, spirochete bacteria. So spirochete. The Lyme disease how the Lyme disease patient present? Can anybody tell me the presentation of the Lyme disease? Super high.
Yes, they will present with the bullseye rash. They will have a history of traveling to the northern part of the United States.
Okay. So it is present with, so the Lyme disease present with facial palsy, right? So
yes.
facial palsy, arthritis, heart block, these kind of the stuff. So the microorganism is a very high yield Borrelia burgdorferi and is a bacteria that is a spirochete, right? And third degree, so the third degree are complete AV block. There is a complete dissociation between the atria and the ventricle. And the atria and ventricle beat independently. Beat independently. So atria ventricle beat independently. So this is P wave. P wave is not followed by QRS. This is again P wave. So this is followed by QRS. So this is P wave, again P wave, this is P wave, this P waves are not followed by QRS. So this is irregular pattern. So the key things, the atrial rate is more than ventricular rate. So this is a P wave, P wave, P wave, P wave, P wave. So 5 P waves and 2 QRS. So atrial rate is more than ventricular rate, right? And it may be caused by Lyme disease. Lyme disease caused by spirochete. Okay. So what is the treatment of this third degree or complete heart block? Again, it is a pacemaker. It is a pacemaker. So this P wave, again, I'm repeating the ECG. This P wave has no relation with QRS. So ventricle beat their own pace while the atria piece. Normally there is a synchrony, there is a harmony between the atrial ventricle depolarization. There is harmony in the contraction and depolarization of the atria and ventricle. But here is a complete dissociation, right? They give you this kind of ECG. Okay, they give you this kind of ECG. You have, and they ask about what is the cause of this ECG. They want to know about Borrelia, right? Sometimes they give you these kind of the stuff, and sometimes they give you the ECG, and they want to know the what is the cause of this pathology. Like if they give you this ECG, they want to ask about the cause. What are the causes of this ECG? Can anybody tell? Beta blockers and athletes. Okay, so same thing here. So what about the cause of this ECG? This ECG basically due to the, it may be due to MI, ischemia, fibrosis, and where the pathology. They sometimes they ask about where is the pathology. So this ECG below the AV node, right?